Good morning, everybody. It's a pleasure to be here. I'm going to switch languages on you. I never had the pleasure of meeting Professor Maravi, but I'm sure I would have liked him because he spoke my language. So, as you heard, my talk today is going to be Complexity, Cognition, Compassion, Geriatric Psychiatry Comes of Age. In terms of my disclosures, I've not received any honorary or research support from industry for over 10 years, but all of the research that I've had has been funded by peer-reviewed funding agencies listed here, and I currently hold grants from all of these organizations. So I really want to try and give you something for everyone today in my talk, and I'm going to try and get you to appreciate the complexity of mental health disorders in late life, to understand the skills, knowledge, and attitudes necessary to diagnose and treat mental health disorders in late life, and then maybe provide an argument for establishing geriatric psychiatry as a designated subspecialty in Israel, and it is not, unfortunately. Along the way, I'm going to try and highlight some of the cool geriatric psychiatry research that I've had the opportunity to be involved with over the last few years. So we're going to start with a geriatric psychiatry case, and this will give you an idea of how a geriatric psychiatrist thinks. This is actually a true case, and or based on a true case that I saw in consultation at Merchavim. This case was quite traumatic for me because it was actually the first case I did after I made Aliyah 6 years ago, and I had to do it in Hebrew, and believe me, this was more traumatic for me than for the patient. So she was a 70-year-old divorced woman who had 3 children. She was a former hospital worker. She was forced to retire 10 years ago because of health issues. She lived alone, but her daughter lived next door in another apartment, and she was admitted through the emergency room a month ago, and I was seeing her on one of the general adult inpatient wards. She was not on the geriatric psychiatry ward. Her chief complaints were, I don't feel good. When I pushed her, she also admitted that she was depressed, hopeless, anxious, and she had multiple somatic complaints that I'll tell you about in a moment. So in terms of her history of present illness, 1 month prior to admission, she became increasingly agitated and anxious. She presented to the emergency room at the hospital complaining of hearing voices telling her to kill herself by strangulation. She was feeling depressed, hopeless, she had no enjoyment in life, and she had feelings of guilt. She did not want to die, but she felt she could not ignore the voices telling her to kill herself. She was sleeping poorly. It took about 3 hours for her to fall asleep a night, and then she would awaken early in the morning. She had poor appetite with some weight loss over the previous month. She saw her family doctor many times prior to her admission, and she was always complaining of weakness, dizziness, and generalized pain. She also complained of difficulty concentrating in memory. So far, there is nothing exciting, nothing specifically geriatric about this particular presentation. What I've done for you is underlined the signs and symptoms of depression that make her a textbook case of major depressive episode. So to remind you, for those of you who are not familiar with the Diagnostic and Statistical Manual of the American Psychiatric Association, that is a cookbook for psychiatric diagnoses. For a diagnosis of major depressive episode, you need one of either depressed mood or anhedonia for the previous 2 weeks, along with 5 of 9 other criteria, and she meets all 9 criteria. So textbook case of major depressive episode at any age. Okay, now let's get into some of the complexity. Her past psychiatric history. She first saw a psychiatrist after she made Aliyah at the age of 18. The reasons for her treatment she could not recall. Her first admission to psychiatry was after the birth of her first child, and she was treated for depression. Again, she did not really recall the details of the treatment. She had several other admissions over the years for depression, and she was followed inconsistently between admissions. She rarely had psychiatric follow-up, and she often stopped medications on her own. Now, around the age of 60, things began to change, and she experienced a marked exacerbation of her illness with numerous admissions for varying lengths of time. We're talking about 3 to 5 admissions per year for the previous 10 years, with multiple discharge diagnoses, including things like major depression with psychotic features, schizoaffective disorder, and borderline personality disorder, among many. She was also treated with multiple medications, including a variety of different antidepressants, antipsychotics, mood stabilizers, and in the past year, she'd even had a brief trial of ECT, which she discontinued on her own because she became too fearful of the treatments. Her past medical history, and again, now I'm really beginning to think like a geriatric psychiatrist because past medical history and medications is very important. So she had hypertension, type 2 diabetes, hyperlipidemia. So she's got multiple cerebrovascular and cardiovascular risk factors. And here, she had a stroke 10 years ago, and remember, the nature of her psychiatric illness changed dramatically 10 years ago. She had a stroke 10 years ago that left her with a mild hemiparesis, but she had complete recovery of her strength. She never drank alcohol or had illicit drug use, and she was a non-smoker. She managed to miss one cardiovascular risk factor. Her current treatments included amlodipine and propranolol for her hypertension. One might question the value of those and the appropriateness of those. Metformin for her diabetes, again, perhaps that's okay, maybe not. She had atorvastatin for her hyperlipidemia, and for stroke prophylaxis, she was on ASA. So again, there's some questions about the appropriateness, the intensity of her medical management of her cardiovascular and cerebrovascular risk factors. In terms of her psychiatric medications, she was taking a therapeutic dose of sertraline, which is an SSRI, a Prozac-type drug for antidepression. She was on quetiapine or Seroquel, 300 milligrams. It's an antipsychotic, but it's used very commonly for treatment of depression as well, and treatment of psychosis and treatment of bipolar disorder. She was on divalproic acid at 500 milligrams twice daily. This is an anti-seizure medication that's probably used more commonly today as a mood stabilizer for bipolar disorder. And she was on clonazepam, 2 milligrams, which is a benzodiazepine-type drug, as a sedative. So in other words, she's on virtually every class of psychiatric medication. In terms of her family history, she had a mother with chronic psychiatric illness who had required many hospitalizations over the years and was eventually chronically institutionalized. And her daughter, her youngest daughter who lives next door, has seen a psychiatrist. So what about her personal and developmental history? She was the youngest of 4 children who was born in Iraq. She repeated 2 grades and never completed high school. Her mother was frequently hospitalized in her childhood, and she was cared for mostly by her grandmother. The family made Aliyah when she was 18 years of age. She worked as a cleaner in hospitals. She had an arranged marriage at the age of 24, 3 children with her husband. Her husband was unfaithful, and she eventually divorced him at the age of 40. She has a reasonable relationship with her children, especially her youngest daughter who lives next door, but was unable to provide much support, and the family was burning out because, as you can imagine, every time she gets admitted, they call on the family to get more history, and they are just sick and tired of being involved in all of this, even though they continue to love and support their mother. By the way, the daughter who lives next door and is the one with the mental health history was admitted to hospital, our hospital, at the same time her mother was. So it gives you an idea of the level of stress in the family. In terms of her mental status examination, she looked like a 7-year-old woman, though much older than her stated age. She was edentulous. That means she had none of her teeth, and she was supposed to wear false teeth because of the weight loss. They were not fitting properly, and so she had no teeth. Poorly kept hair, hospital clothing. She had no spontaneous speech, but answered questions appropriately when asked, and there was decreased eye contact. She looked depressed and hopeless. She felt guilty and anhedonic. She had a generally flat affect. She was not tearful, and she denied active suicidal ideation. In terms of her thoughts, she had multiple somatic preoccupations. I don't feel good. I've got pain all over my body, but nothing very specific. She had no clear delusions or ideas of reference, no disorders of thought process. And in terms of her perceptions, she had auditory hallucinations. She heard a man's voice telling her to strangle herself, and she felt that she could only ignore these commands if she remained in hospital. If she would be discharged, she felt she would have to listen to these commands to kill herself. So, some of this is very nuts and bolts, bread and butter psychiatry, and now we're thinking a little bit more about geriatric psychiatry, and the question becomes, should we screen cognitively a patient like this? And my role as a geriatric psychiatry is yes, every older person that presents with a mental health problem should be screened cognitively. And this particular patient has many, many good reasons to screen, particularly given her cerebrovascular history. So unfortunately, this is where my practice has changed dramatically compared to my days in Toronto. As a geriatric psychiatrist who specialized in memory disorders, I would usually spend an hour examining the patient and then do an hour of cognitive testing. Because of my very poor Hebrew language skills, the best I could do for this patient, in particular because it was my first patient doing a consult on after I arrived in Israel 6 years ago, was to do the mini mental state examination. Now, many of you probably know the mini mental state examination was first published in 1975. It has the largest number of citations of any psychiatry publication ever produced. Can you believe it? The number one, most citations, thousands and thousands and thousands of citations. But it is a simple 30-item screening test for cognitive function. It's been translated into 40 or 50 languages. It's available, as you can see, I give you an example of one that's in Hebrew, English, and in, I guess, Russian. It is reliable, it is valid. It has a number of particular weaknesses. We're not going to go into details about the mini mental state examination, but this is what I did on her. So on cognition, she scored 20 out of 30 on the mini mental state, and to remind you, a score of 24 or less is indicative of significant cognitive impairment. In terms of her exact problems, she did not know the day or the date. She lost 3 points for concentration, 2 points for delayed recall, so that's memory, or semantic memory, 1 point for repetition, 1 point for writing a sentence, and 1 point for copying. Now, the biggest, as far as I'm concerned, as a memory specialist, the biggest problem with the mini mental state examination is that it doesn't really test for executive function or frontal lobe functions. So again, if I'm really pressed for time or if I don't have good enough language skills, I ask the patient to do clock drawing. And what we do with clock drawing is we give the patient a blank piece of paper and we either draw a pre-drawn circle or we just tell them to draw the circle. We tell them to draw the face of a clock, putting in all the numbers and setting the hands at 10 minutes past 11. And I'll show you why we do 10 minutes past 11 in a moment. But this was her clock. And let me see if I can get the pointer. Can you see it? Yeah, but I can't do. Okay, so as you can see, she puts in all the correct numbers, right? 12 to 11, she gets the numbers. The spacing is not great. She ignores the contours of the clock. I drew the circle. She ignores the contours. That suggests a little bit of visual spatial impairment, as well as the spacing might be visual spatial. It might be planning, which is an executive function. But here's the really cool thing. When asked to draw the hands at 10 past 11, and remember, when you say 10 past 11, you have to use abstract thinking to know that the 10 passes the 2 and not the numeral 10 on the clock. But she makes that mistake, right? She completely misses the 10 and the 11, but she puts the hand where you would normally think 10 to 11 would be. So she gets what we call executive pull. She gets that frontal pull because she cannot make abstraction. Her abstract thinking is impaired. Okay, here's another difference between a geriatric psychiatrist and an adult psychiatrist. We are supposed to do physical exams on all our patients, and I did. And what I found was that she was mildly obese. She had mild buccolingual movements. This represents tardive dyskinesia, which is likely an effect of all of the antipsychotics that she's been on through the course of her life. She had very mild tremor and cogwheeling. This is Parkinsonian symptomatology, and that can be as a result of the medications that she's on, like the antipsychotic. It could be a result of her cerebrovascular disease, or it could be Parkinson's disease. She's in the right age to start developing that. She had a slightly shuffling gait and slightly unsteady, again, for all the reasons that I mentioned with respect to the Parkinsonism. Her strength was equal in all limbs, so the history that we got that she recovered completely from the stroke, at least from a physical perspective, was correct. She had slight decreased sensation to pinprick bilaterally in her feet towards her ankles. Thank you. Okay, so what does that represent? That represents the diabetic neuropathy, again, suggesting to me, at least, that maybe her diabetes was not optimally managed. So I'm going to be thinking about that in terms of treatment. Okay, so what were my DSM diagnoses? To remind you, in Israel we use the International Classification of Diseases, which is the ICD, but in fact all the psychiatrists in this country use the DSM, which is the Diagnostic and Statistic Manual of the American Psychiatric Association, now in its 5th edition. By the way, it's exactly the same thing in Canada. We're supposed to use ICD. We do not. We use the DSM. So here, Israel and Canada are very similar. So my provisional or working diagnosis was major depressive disorder, which was severe with psychotic features, and I added the proviso of being treatment resistant. I also said, and this was new, that they hadn't considered before, that she had a mild neurocognitive disorder. And to remind you, this is equivalent to MCI, or mild cognitive impairment, which every other group of physicians use the terminology. Psychiatry, we believe that dementia or mild cognitive impairment is pejorative terms, and so we have fancier, nicer names. It's kind of like Dr. Maharavi said. He likes the word zkeinim, and I agree. I agree with him. Call it what it is. So anyways, the DSM calls it mild neurocognitive disorder. So this is where you have significant cognitive impairment that does not interfere with activities of daily living. Now again, she might meet the criteria for dementia, but I'm going to need to do more testing to figure out if that's the case or not, based on her actual functioning, which we can test or which we can ask the family about. So I thought the mild neurocognitive disorder was likely due to cerebrovascular disease, but we would have to rule out Alzheimer's disease, dementia with Lewy bodies because of her hallucinations and her Parkinsonism, and then the more likely possibility that we're dealing with the mixed dementia. In terms of the differential diagnosis, I wanted to rule out depressive disorder due to another medical condition. In this case, it would be cerebrovascular disease. Bipolar disorder, again, she was on a mood stabilizer, and although I had no clear history of manic episodes, this would be important to determine by looking at her medical records, as well as by speaking to the family. Schizoaffective disorder, and then somatic symptom disorder because of the very prominent physical complaints that she had. Now, I'm going to leave the case for a few minutes, and I'm going to come back to it to discuss it in detail a little bit more. But just I want to take a little bit of a detour and talk about why we should bother with geriatrics. And again, if you're here, you should probably be able to answer this question. But just to remind you, we're talking about a very large swath of life these days. But where did 65 come about? Where did this cutoff of age 65 come out? Is it something arbitrary? And the answer is, yeah, maybe, but not really. It comes from Otto von Bismarck, who introduced Social Security in the late 1800s in Germany for people over the age of 65, and they chose 65 specifically because that was the average age of death for most people in Germany, and this way the government would not have to pay a lot of Social Security. So that's where 65 came about, from Otto von Bismarck. There are obviously very important current demographic pressures. In Israel, the life expectancy is now 82. That's the 7th longest or oldest in the world. 84.5 for females, 80.5 for males. The gap between males and females is narrowing. And people over the age of 90 is one of the fastest growing segments of Israeli society. So why are older folks different? Sorry, the slide did not come out well on this. Anyway, so there are lots of things that are going on normally as people age. These normal changes include things like the neurotransmitters and their receptors. So monoamine oxidase, the enzyme that breaks down the monoamines in the brain. Monoamines are things like norepinephrine and dopamine, serotonin. That is increasing in late life. Interestingly, we always think about late life things decrease, but actually that increases in late life. D2 receptors, or the dopamine D2 receptors, decrease in late life, making patients more sensitive to extrapyramidal symptoms. Alpha adrenergic receptors change in terms of their sensitivity. Their metabolic changes, including a significant change in volume of distribution and creatinine clearance or kidney function, which is going to have significant implications for the drugs that we use. There may be cognition changes. This is an interesting area of research. There's been 50 years of research on this, and you still really don't know if there are changes that are important as people age, or if it's the fact of underlying pathology. We know that psychomotor changes that do occur, that people slow down in terms of their thinking and their cognition, but that might be the only thing that is truly different as people age. Unfortunately, as people get into their 60s and 70s, chronic and acute medical illnesses become much more common, and that's going to have a very significant effect on mental health and medications. As you know, on average, people over the age of 65 in virtually every Western country of the world take on average 10 prescription and over-the-counter medications. So there are huge numbers of medications that can affect cognition and mental health in late life. There are specific life cycle events or stressors that our elderly population has to deal with, including things like retirement and bereavement, and even the psychological adjustment to chronic medical conditions. And then there are service delivery issues, and in Israel, unfortunately for me, the geriatrician is king and not the geriatric psychiatrist. What do I mean by that? Well, geriatric medicine became a subspecialty, a recognized subspecialty in 1984. Right? 40 years ago, geriatric medicine was already recognized as being important and became a subspecialty. Geriatric psychiatry is still not a subspecialty in this country. One of the reasons that geriatric medicine became so prominent and so important is this man here. This is Bernard Isaacs. Bernard Isaacs was the first professor of geriatric medicine. He was a professor of medicine at Birmingham University in the United Kingdom. And he came up with the geriatric giants. Okay? The main focus of geriatric medicine: impaired vision and hearing, incontinence, instability, and impaired cognition. Great, great way to remember the focus of geriatric medicine. The really cool thing about Bernard Isaacs is that he was a devout Zionist. He made Aliyah in 1991, and between 1991 and 1995, he was very actively involved in medicine and geriatric medicine in Israel. So that's another reason why geriatric medicine is king in this country. If you're going to do geriatric psychiatry or geriatric medicine, you have to have the geriatric mindset, and that is to avoid ageism, also known as gerontophobia, to have patience, to expect occasional cures, but to always demand care, to be more focused on quality of life than on quantity of life, to always maintain hopefulness, and to avoid the aging myths. So here is a great quote. What is gerontophobia? Here's a great quote, and this is an important quote because it comes from the first textbook of geriatric psychiatry, published by Alex Comfort in 1980. And this was like a tiny, tiny textbook, maybe 100 pages long. Now we have geriatric psychiatry textbooks that are 1,000 pages long. But this was a tiny book. And what Comfort said was, unique to our culture is its rejection of the old, their exclusion from work, and their accustomed social space, their premature burial by society as unpeople, and a rich and erroneous folklore of mental decline, infirmity, asexuality, ineducability, and the normality of causeless mental disorder in the old. Beautiful quote, beautiful quote. And I get you to focus on this word, ineducability. So some of you who come from a psychology background may know that Sigmund Freud said you should not do psychoanalysis in elderly patient populations because, not only because from a practical standpoint, you wouldn't have a lot of years to benefit from the improvement that you might get from psychoanalysis, but because they were ineducable. Okay, so that's where that word came from, thanks to Sigmund Freud. Of course, the new term is not gerontophobia, it's ageism, and you're all familiar with that. And we owe another Jewish psychiatrist credit for, again, contributing to ageism or gerontophobia, Samuel Shem. Any of you who are medical students or planning to go into medical school, you will read this book. It is a standard book for interns and residents called The House of God, published already in 1978. And Samuel Shem coined the term Gomer, get out of my emergency room, to refer to an elderly person who comes in every night and has the usual kinds of elderly patient problems. Okay, geriatric psychiatry, having said all that, is a very young subspecialty. Here's another important Jewish contributor. Martin Roth, who was eventually knighted and became Sir Martin Roth, was born in Budapest. His father was a chazan, and they made aliyah to England to escape the Holocaust, and he became one of the first professors of geriatric psychiatry. He actually is even more famous in the world of psychiatry for a textbook. He wrote one of the most important psychiatry textbooks called Clinical Psychiatry by Slater and Roth. But he did a very simple study in 1955 where before that, if you reached the age of 65 and you ended up in a hospital for mental health problems, the diagnosis was arteriosclerotic dementia. Okay? You had hardening of the arteries, and any symptoms or problems you had were related to hardening of the arteries and arteriosclerotic dementia. So what he did is he went to a large psychogeriatric unit, and he actually tried to diagnose the patients, and indeed what he found was some people had major depressive episode, and they got better, and they were discharged. Some people had chronic psychotic symptoms, and they looked for all intents and purposes like they had schizophrenia, even though they were 70 or 80 years of age. Some people, had delirium. They were cognitively impaired for a short period of time, and then they were discharged. And finally, some people had chronic cognitive impairment that got worse and eventually died as a result of it, and they had true dementia. But that was the first time we recognized that patients over the age of 65 could actually have other types of mental illness besides arteriosclerotic dementia. So the roots of geriatric psychiatry were in England in the 1960s and 1970s. The Royal College of Psychiatrists established a faculty of old age psychiatry in 1973. We take credit in Toronto for having the first university academic division of geriatric psychiatry, which was established in 1978. And then in the late 70s and early 80s, things really began to expand quite dramatically. The American Association of Geriatric Psychiatry was established in 1978. The International Psychogeriatric Association was established in 1982. Subspecialty recognition, so as a subspecialty of psychiatry, was first recognized in the United States and Britain in 1989. Canada was slower in 2009. So we've talked about some attitudes, we've talked about some knowledge base. Now we're going to think a little bit about the skills you need to be a psychogeriatrician. And I'm not going to go into this in detail, but just to remind you that when we think about the personal history, we're going to focus on the geriatric life cycle events, as I mentioned, particularly like retirement. Some of the younger ones would be younger children leaving home. Today we have older children coming back home, and spousal bereavement and other types of bereavement. Medical history we're going to focus on. Again, as I mentioned before, we want to take a very careful history of both prescription medications as well as over-the-counter medications. We're going to do a physical exam, and the mental status exam we're going to include some cognitive screening, and then we have to think about competency, which other psychiatrists don't always think about. We want to think about personal capacity, capacity for personal care. So can they make treatment decisions? Can they manage their finances? Do they have testamentary capacity? This is often a problem that geriatric psychiatrists are asked to comment on. Do they have a risk of wandering? Do they have a risk of falls? Is there the potential for neglect, including both physical and financial neglect? And of course, are they still driving, and should they still be driving? Okay, so we took that little detour. Let's go back to our case to think more about how geriatric psychiatrists think. So let's talk about depression in the elderly. How common is it? Is it similar to depression earlier in life? Is depression treated the same way in the elderly? What are the implications of this patient's suicidal ideation or these auditory hallucinations of telling her to kill herself? What about her cognitive impairment? And what about her history of stroke? So we're going to try to touch on all those issues. So first of all, in terms of depression in the elderly, this might surprise you if you're not already aware of it. If anything, some of the research suggests that depression in late life is actually less common than the depression in earlier life. So in one of the landmark large epidemiological studies done in North America, the ECA, or Epidemiological Catchment Area Study, the prevalence of depression was 1% in geriatric patients, people over the age of 65, compared to 2 to 3% in younger patient populations. And of course, that leads to the question about, is late life depression really less common in late life? And generally, we say it's probably not. And the reason that some of the studies suggest it is likely has to do with where you're assessing patients. And if you don't think about all the patients that are in chronic institutions, in Be'er Yaacov, in rehabilitation hospitals, so on and so forth, you may miss a lot of patients, or you will miss a lot of patients with depression. So you have to think about sampling when you're doing epidemiological studies in the elderly. So for example, the Canadian Study of Health and Aging that was published after the ECA came to a figure of 11.2% for significant depressive symptoms in patients over the age of 65, and that's because they actually oversampled nursing homes and chronic care institutions. Again, depending on where you look, you're going to see different amounts of depression. So it's been suggested that there are significant depressive symptoms in 30 to 50% of ambulatory care patients. In the Be'er Yaacov, up to 25% of patients might meet criteria for major depressive episode. But the important thing to remember is that the signs and symptoms of depression are similar at all ages. So you can still use the DSM-5 criteria or the ICD criteria for diagnosing a major depressive episode. Now, some of you may be thinking, yeah, I don't believe that, because every depressed patient I see, like our patient or like my patient that I've just described, has multiple somatic complaints, and that must be the sine qua non of depression in late life. However, there's also been studies that have looked at that question. And what did they find is that if you actually control for the number of true physical illnesses that the patients have, there is no difference in terms of how frequently people complain about physical complaints, whether they're young and depressed or whether they're older and depressed. So really, no significant difference in terms of presentation. Okay, what about the significance of cognitive impairment in our patient? Is it a symptom of depression in the elderly? Is it a symptom of dementia? Is it a symptom of the stroke? So here is where we talk about what was preoccupying geriatric psychiatrists during the 1970s and 1980s. And this was the concept of pseudodementia, a syndrome of major depression occurring most frequently in the elderly, not exclusively in the elderly, but most frequently in the elderly, that was characterized by chief complaint of cognitive dysfunction associated with cognitive deficits that resolved with effective antidepressant treatment. So the patient came complaining of cognitive impairment, complaining that they had Alzheimer's disease, okay? And in fact, in our textbooks, in the early textbooks, we would have these great charts that made it simple to diagnose the difference between depression or pseudodementia and actual dementia. So with pseudodementia or depression associated with cognitive impairment, you had abrupt onset as opposed to insidious onset with dementia. You had a family or personal history of depression in patients with pseudodementia. The most important chief complaint was the ability to function cognitively, and so on and so forth. So you had these great charts that help distinguish between pseudodementia and dementia. Easy to diagnose. And that is what geriatric psychiatrists focus on. If you asked a geriatric psychiatrist in the 1970s or 80s, what makes you so special? They could tell you, I can diagnose dementia and I can diagnose depression. And a lot of people that complain of dementia, they don't have dementia, they have depression. And when I treat them, they're going to get better. Okay? Well, then reality strikes. And reality is always in the form of what happens with research. And this is a paper by George Alexopoulos from 1993, where he showed that when you compare a group of elderly patients who meet all the criteria of pseudodementia, in other words, they had complaints of cognitive impairment, but they had depression, and they improved with antidepressant therapy, compared to patients that do not present this way, they present with the classic symptoms of depression, and they never complain about cognitive impairment, what you find is that those with pseudodementia, if you follow them for more than 3 years, they drop off a cliff. and virtually all of them, so 90%, by the time 5 years later, will have developed an actual dementia. Okay? So pseudodementia was not pseudodementia, it was pseudo-dementia. Okay? It was dementia. Okay? It was a prodrome of dementia or an early manifestation, and I know Professor Ravona is going to be talking all about that, so I'm not going to go too much more into that. But I also want you to take a look at the group that had no evidence of cognitive impairment when they presented initially. And look at that. When you follow them long enough, 40% of those developed dementia. The plot thickens. So depression in older adults is associated with approximately a twofold increased risk of Alzheimer's disease. And that's whether you develop depression in your 20s or 30s, or whether you develop it in your 70s or 80s. Depression may be an early behavioral manifestation of Alzheimer's disease. That's Dr. Ravona, or Professor Ravona's talk. Or it may be a true risk factor for Alzheimer's disease. Some studies have demonstrated an association between early life depression and increased risk of Alzheimer's disease, but most studies have observed a more substantial risk when depression has been active in later years. This is one of the first studies I'll show you of mine. This was published 2 years ago, and it looked at an association between depression, gender, and Alzheimer's disease with neuropathology, cross-sectional study of 407 older adults from the NACC study in the United States. Those with recently treated depression but not remote depression were more likely to have higher Alzheimer's disease pathology with an odds ratio of 3.7. So they were more than 3 times more likely to have Alzheimer's pathology compared to those that did not have that history of recent depression. And we concluded that the relationship between late life depression and Alzheimer's neuropathology is associated with spread of amyloid pathology in the neocortex, the allocortical areas, and subcortical regions that were critical for regulation of mood and motivated behavior. So, can cognitive impairment associated with depression be prevented? Okay, so here is a study that I published 2 or 3 months ago in JAMA Psychiatry, Slowing Cognitive Decline in Major Depressive Disorder and Mild Cognitive Impairment, a randomized clinical trial. This was a trial of 375 older adults with both remitted depression and or mild cognitive impairment. So you could come into the study either having a history of depression and now you were thymic, or you could have a history of mild cognitive impairment, present with mild cognitive impairment. 375 of these, and what did we do? We gave them transcranial direct current stimulation and cognitive remediation. So we brought the patients into hospital 5 days a week for 8 weeks. Can you imagine this? For a full day. And got them to play computer games while they were getting brain stimulation. And then we did a week of boosters every 6 months, and we followed patients for up to 5 years. So this preoccupied the last 15 years of my academic life. What we found was that transcranial direct current stimulation and cognitive remediation slowed cognitive decline in older adults with both remitted depression and MCI, but there was a larger effect on people with remitted major depression, a very significant effect. By the way, this is what transcranial direct current stimulation looks like. It's a tiny machine that works by a 9-volt battery. So it is a scalable treatment. It's not like the magnetic stimulation machines that you may have heard about. So it's a very simple neurostimulation procedure, and it's being actively investigated, and we're hoping to repeat the study shortly, focusing actually on patients with remitted depression. What about the patient's suicidal ideation? So as you know, suicide is a major mental health problem. It's one of the leading causes of death, the second leading cause of death in people between the age of 15 and 29, according to the World Health Organization. Unfortunately, the latest suicide figures I could get from Israel, and I guarantee you they're different now, was from 2014. It was 6.3 per 100,000. And the highest suicide rate among both sexes was recorded at age 75 and above. There's actually 2 peaks in life. There's late adolescence and early adulthood, and then there is late life. But the elderly are experts at killing themselves. And that's because they use more lethal methods. They have a much lower attempt to completion ratio. So in the young, you have 20 attempts for every completed suicide. In the elderly, it's 4 attempts for every completed suicide. So again, every time you hear suicidal ideation from an older patient, you must take it seriously. They give fewer warnings, and of course there's a distinct nature of stressors. But what about the effect of medical illness in suicide? And this is another study that I did with a fabulous PhD student. And we looked at the association between medical illness and risk of suicide in the elderly. And what we did is we compared, we went to the coroner's report in the province of Ontario, and we got all the completed suicides of people over the age of 65. We had 1,329 coroner's reports for completed suicide, and we compared them to age and sex-matched controls who did not commit suicide. And what we found is that the risk of suicide increased linearly with the number of medical illness. And look at this. You can draw almost a direct straight line between the number of chronic medical illnesses and the risk ratio for suicide. This is the nicest graph I have ever done in any of my research to date. I'm so proud of this. Okay, what is the significance of stroke in our patient? So here I'm going to refer you to the Sunnybrook stroke study. This was one of my first large epidemiological studies, prospective study of depressive symptoms and functional outcome, which I published in Stroke in 1998. So this goes back quite a bit. Prospective study of hospitalized stroke patients that were followed at 3 and 12 months. We looked at 436 patients with ischemic stroke, and what we found was that depressive symptoms, significant depressive symptoms, in other words, meeting cutoff for the individual scale, occurred in between 22 and 27% at post-stroke patients at 3 months, and between 21 and 22% of patients at 1 year. The difference between the first figure and the second figure is that the first figure is based on an objective rating scale, and the second figure is based on subjective rating scales. So previous depression and alcohol abuse increase the risk of post-stroke depression. If you're female, you're more likely to become depressed after a stroke. If you've had a previous stroke, you are more likely to become depressed after a stroke. But the most important risk factors for post-stroke depression are stroke severity and the severity of the physical disability associated with it. Cognitive impairment also increased the risks of post-stroke depression. Lesion location has been an active area of research for many, many years. I don't want to go into it. It's very cool research. It probably has a lot less to do with what we originally thought it had to do. We had all kinds of beliefs, including if you had a left-sided stroke, you were more likely to become depressed. If you had a frontal stroke, you were more likely to become depressed and depressed seriously. Today we know it's probably not the case, or that effect of localization is much less. Stroke severity and physical disability is much, much more important in terms of a risk factor. I started 10 minutes late. Yeah, baloney. Okay, back to the case. Summary and formulation. So I thought this was a 70-year-old woman who was admitted with severe depression and auditory hallucination. She had a lengthy psychiatric history, medical history notable for stroke and multiple vascular risk factors. She was presenting with depression, somatic complaints, command hallucination of self-harm, and cognitive impairment. And what did I think? I thought that she was genetically predisposed to depression with her family history, multiple life stressors, cerebrovascular disease, again, predisposed from a genetic and developmental effect, as well as the effect of medications that she was taking, which worsen and perpetuate her underlying depressive disorder and contribute to her treatment resistance. I thought she had cognitive impairments from cerebrovascular disease, but we must rule out mixed pathology, including Alzheimer's disease. So, back to treatment. So what did I say? First of all, the patient should remain in hospital, and that was because of her suicidal ideation. Second, I thought it was absolutely crucial that she get further investigations. We needed to do more neuroimaging. She hadn't had a CT scan or an MRI for 10 years, and it would be very important to document whether there's been a progression of cerebrovascular disease, whether she's had any new strokes that could account for some of her symptomatology. I wanted endocrinology to look at her for her diabetes management. I wanted neurology to look at her for her stroke prophylaxis. And importantly, I wanted neuropsychology to characterize her cognitive impairment. Again, because she had poor educational attainment, because Hebrew was not her first language, it would be very important to make sure that a neuropsychologist can administer standardized tests that take into account Hebrew as a second language, as well as her poor educational attainment. I wanted occupational therapy to do a functional assessment so we can decide whether it's true mild cognitive impairment or whether in fact she meets criteria for dementia. And I wanted social work to get more history and determine what exactly was the nature of her family resources. In terms of treatment, I suggested that they go back to ECT, electroconvulsive therapy. For those of you who don't know, there is evidence, very good evidence, of excellent efficacy in the elderly. Even some people suggest that it might be better efficacy again compared to younger patient populations, and there are potential reasons for that. There's excellent tolerability in the elderly. It's not contraindicated because of a stroke. It's not contraindicated because of her cognitive impairment. So in my last 2 minutes, I'm going to try and answer the question, should Israel recognize geriatric psychiatry as a subspecialty? One of the first things I did when I arrived in Israel was I wrote an article with Ramit, published in the Israel Journal of Psychiatry, titled Old Age Psychiatry in Israel, a Subspecialty Long Overdue, where we tried to make an argument for geriatric psychiatry subspecialty recognition. And what we made the argument based on is the demographic imperative that we've already talked about. Geriatric psychiatrists have specific knowledge, skills, and attitudes that allow them to provide optimal care for older persons with mental health problems. Today in Israel, most of the psychogeriatric care is done by geriatricians, and I don't think that is optimal. Geriatric psychiatry is already well established as a subspecialty in the rest of the world, as I already told you about, and there are resources that already exist in Israel. The Israel Society of Old Age Psychiatry has over 100 members. There are geriatric psychiatry specialty services at some hospitals, including Sheba and my hospital, Merchavim. And since 1991, the School of Continuing Medical Education at Tel Aviv University has organized postgraduate diploma courses, much in thanks to Professor Ravona and Daphna Shefet. And again, in terms of fairness, geriatric medicine was recognized 40 years ago, so hasn't our time already come? Even though I wrote that in 2001 and it is 2005 today, I'm not totally hopeless because I think there's still an opportunity for Israel. So just to let you know, in 2004, I wrote a very similar article in the Canadian Journal of Psychiatry, Geriatric Psychiatry, a specialty whose time has come, and geriatric psychiatry became a subspecialty 5 years later in 2009. So if I use the same thing, maybe next year, geriatric psychiatry will be recognized in Israel. So my conclusions: demographic pressures alone argue for a need for geriatric psychiatry specialists and services. Geriatric psychiatrists have specialized knowledge, skills, and attitudes to diagnose and treat mental health problems in late life. Israel needs more geriatric psychiatry training and geriatric psychiatry subspecialty recognition. And finally, Israel needs more aging research. Thank you.
וואו, איזה... סליחה? הרצאה עוצרת נשימה שניתנה בקצב של ריצת ספרינט מרתון. אני רוצה להודות לפרופסור הרמן, ואני חושבת שמדינת ישראל זכתה בזה שאנחנו אבן שואבת ליהדות העולם או לרופאים מצוינים שבוחרים להגיע לכאן ולתרום לנו. אני מודעת לזה שהנושא הוא קונטרוברסיאלי וייתכן שיש כאן גריאטרים שיש להם מה להגיד על ההרצאה, ודווקא זה פתח מעולה לשולחנות העגולים שאנחנו נקיים אחרי הצהריים. אני גם חושבת שאנחנו מבינים שהאוסף של ההרצאות והדברים שאנחנו שומעים כאן הבוקר הם מכינים את כולנו לקראת הדיונים שאנחנו נקיים אחרי הצהריים. אני מזמינה את כולנו, אני מזמינה את החוקרים הצעירים לעמוד ליד הפוסטרים שלהם, ואני מזמינה את כולנו לצאת לחצי שעה הפסקה ונתכנס כאן מחדש ב-11 ונמשיך לשמוע הרצאות מאלפות. אז תודה רבה.